athlete. He was an all-star high school athlete as well. And he's been hampered by a few hamstring injuries, been setting him back. What really set him back was he texted me over the weekend a couple months ago, says he started getting some weakness in his legs and then started getting weak in his arms. And I said, come into my office. And this 19-year-old D1 athlete could barely climb the stairs up to my office. I assessed him. He had decreased tendon reflexes and he had classic GBS symptoms. So I sent him to the ER where they did a full workup on him. They did CAT scan of his brain and they did a lumbar puncture. And they didn't diagnose him with any infectious etiology, but they diagnosed him with GBS and they treated him with IVIG. And so he recovered fairly well from this. And then he went back to college, off in Kansas. I started playing again, hampered by a hamstring injury again. So he quit D1 athletics. He actually quit college and he got married. We thought everything was good. He's going to do something else in life. He started getting into mixed martial arts. When again, this was on the 16th, he texted me, same thing, weakness in his legs, in his arms. We knew exactly what this was. We sent him to the hospital. Again, CAT scanned his brain, CAT scanned his lumbar spine, lumbar punctured twice, full workup with no answers. They didn't find any infectious etiology. Again, they said it's GBS, maybe some encephalitis, we don't know. Gave him the IVIG. I saw him in my office on the 25th. I said, that's it. We're going to look for some stealth infections. So I ran the Vibrant stealth infection panel. And, this cost about $1,000 to run this test. It was a shotgun approach. We looked at all things. He has multiple positives for Lyme serologies, IgGs. He has very elevated IgGs to Epstein-Barr virus, to cytomegalovirus, to streptococcal A, and even some maybe inconsequential ones. Maybe you tell me some parvovirus. So a lot of viral reactivations. He does have an interesting family history. His mom suffered for a long time with CMV. No, with CMV, with Epstein-Barr virus. And she asked me, is this inheritable? Can you inherit Epstein-Barr virus? Or do you have a genetic predisposition to Epstein-Barr virus? So the question was, can you inherit something like this? We all know there is vertical transmission. You can pass on viruses to your offspring, but we know that Epstein-Barr virus is, through transmission, contact transmission. So that's where we're at with this kid. We put him on the peptide protocol, BPC 157, TB 500 for his nerve injury. He's still weak in the left leg. He had some EMG testing done showing some basically neuropathy. And we want some answers. We want some treatment. So I already put this kid on Valtrex, 1 gram 3 times a day for the EBV, but we're left with potentially Lyme and treating Lymes. And that's what today's discussion is about, Lyme and co-infections.
Well, that's actually perfect because that is the big thing, at least from my perspective. My question is on him, though, at the moment is, what about his antibodies? Which pathways, neural pathways, did he have antibodies for, if you have that information? And I'm curious about aquaphor antibodies.
Not familiar. Explain what an aquaphor antibody is.
Aquaphor antibody is it's an antibody response to the part of the brain that sort of filters it's the barrier between the brain and the cerebral spinal fluid, and it involves the oligodendrocytes, I believe, or they're called podocytes, which are sort of the feet sort of hold that brain barrier intact, and when that gets disrupted, then the brain, this is sort of a basic outlay, then there's sort of leakage into the cerebral spinal fluid, which increases inflammation to the spinal cord, and can ultimately turn into a peripheral demyelinating condition as well. So it's sort of the cousin of multiple sclerosis.
Okay.
Does the Vibrant NeuroZoomer check for all that or what?
Yeah,
No,
if you got the NeuroZoomer, it should be on there.
didn't order that. No, I just did their stealth infection panel.
Okay. Stealth infection. So it doesn't have the neural antibodies.
No, it's called their tick-borne diseases 2.0, and I put it in the chat all the positives that he has. It's a large
Okay.
infection burden.
Okay. And when they said, well, he's got classic Guillain-Barré syndrome, what do we know what exactly lab that was or was
Lumbar puncture, they did that to try to identify if there was a problem. I think it was more of a diagnosis of exclusion. And then there's a clinical diagnosis just because it was so classic. It went from ground to upper extremity, progressive weakness, but they couldn't find an etiology for it.
Okay, so I would definitely get the neural zoomer because that will show antibodies to all of the different neurological pathways, even those that point towards Guillain-Barré versus aquaporin antibody. It would be that would be optic neuromyelitis, and some people will have an eye component, some people won't, and that's what my patient in New York has.
Fascinating because his mom has something similar. She's gone legally blind uh, from something they don't know what. She does have EBV chronically. She's gone legally blind from it.
Yeah, and did she have other symptoms in her
Yep.
neurologic in her arms and her
Uh,
feet
fa- yeah, it's just fatigue, general malaise, that sort of deal. Yeah.
and some neuropathy and weakness in the extremities at all? Do you know? Or
Yes. Yeah. Just general weakness overall.
okay, yeah, I would definitely get the neurozoomer because that to me gives more answers than at least any other test that I've come across. And again, it allowed me to comfortably diagnose my patient up north. I mean, they've seen everybody. They've seen neurology and endocrinology and that, every different specialty. And this was spot on. I mean, everything he presents with, from it depends how advanced it is. But I mean, up until now, that's the only firm diagnosis that we have. Now, what I do see is Epstein-Barr active, and I see cytomegalovirus active, streptococcal A active, and where I've been sort of placing things in the order of importance, what's causing what is really at the center of it all is chronic Lyme disease. And the reason why that's confusing is because I don't think that Lyme disease, what shows up on these tests, is actually what we think of Lyme disease from the 1990s with the classic swollen tick bite, with the swollen joint. Um, it's not that. And in fact, it doesn't even show up positive on the traditional tests. They might have maybe a couple markers out of so many on the conventional tests, which are not really, you have to have like 5 or 6 in order for it to qualify for Lyme. And I'm thinking there is something missing in that when I do the neurozoomer tests, they test positive for Lyme and they will say which fragments will lead to which antibodies in what part of the brain. It's very specific. And I think in reality, it comes down to the fact that either it's like getting a CBC and a CMP, it doesn't really give you the full picture. Sometimes we have to go to these specialty tests to get more clarity. And the Lyme tests always seem to be really inconclusive. I don't think that that's the case at all. I think what it is that all of these parasites that people are talking about and these issues are actually, you could comfortably, at least I can, consider it to be all sort of a chronic Lyme spectrum. And when you look at Lyme as being a persister, it's a mimicker, it's a shapeshifter. It looks like this, it looks like that, it can look like this, it can mimic that. It pretty much covers all the bases. And when you run these tests, you can never get something that's specific for a parasite that is specific for an antibody in the brain that is the driver for the issue. Say in my patient with the aquaporin antibody, that's a very straightforward diagnosis. In fact, we have somebody at the clinic who's had that for like 5 to 6 years. Difficulty with walking, neuropathy, sort of not necessarily happening all at the same time in both upper and lower limbs. It came down to the point where he ended up getting an MRI of his C-spine. His actual spinal cord showed signs of inflammation and swelling. And he ended up having surgery.
Wow.
And there seems to be a direct connection between that and Lyme antibodies. And a lot of it has to do with genetic predisposition. If they have the genetic polymorphisms that make them
Prone to it.
Yeah, I would say make them more vulnerable to that specific part of the blood-brain barrier versus somebody who has generalized brain fog, which would be, directed towards the dopaminergic antibodies. In fact, if you look at it, you'll see people have antibodies to everything. It's just a matter of what's super high.
Right.
Usually
Well,
it's high.
if you have a patient, they have neurological problems. They have brain inflammation, and then we have here some signs that there's lots of co-infections. I mean, I could do a neurozoomer, but I'd like to start treatment before doing that. What would be your suggestion for this?
Well, I think that's going to tie in my lecture here and give us some ideas. Now, keep in mind, this lecture, like a lot of things, are things that I just sort of came to realize, or that the strategy makes more sense now, whereas nothing made sense to me before. Suddenly I'm seeing the light. And I guess once we go into it, the question is, well, how do you treat Lyme's? I thought you could only treat it within the first 3 days or something like that in order to actually get rid of it before it actually does something. Well, then what do you do in these situations? That was always the question. Do antibiotics work? Why don't they work? That was always my question. And so this lecture, I think, clears that up, and it's going to give more of a semi-conventional method, how to go about it. And then I think we need to start talking about herbal remedies, because I never understood them. I wish somebody would have said somewhere, oh, this is why people take herbs, not just, oh, I feel okay, I like it. No. What is it doing? Well, when I found out what they can do, if you have the right combination, it actually makes perfect sense. It makes perfect sense. And I'll give you a hint. It has to do with the persister cells. And the persister cells are like spores. They don't call them spores. They're like spores. And this is where the language of all this stuff starts to come together, and all the confusion and all oh, you got to do this when it's a full moon. Oh, is it parasites? Is it this? Is it that? Is it Lyme? Is it the other stuff? But the reality is, what I'm seeing is the common denominator is a spore, or what they call a persister cell. And what it is very hard to break, because it's like glass. It's like liquid crystal. It's exactly what I see under the microscope, but I guess that can't talk about that stuff. Right? I know. such a weird, I feel like I'm in the Twilight Zone. Oh, you can't look under the microscope? Okay, let me
Yes, please share your screen and we'll get started here.
okay, can you hear me okay?
Yes, you're loud and clear. Go ahead.
Okay, so, and I don't have pictures, so you're going to have to conceptualize in your mind, but you have to imagine that everybody's positive for Lyme. Just imagine that that's the case. I actually think that it's the case. Everybody I've ever tested for it now over the past year is positive.
It's not
It,
from ticks then. Where is it coming from?
well, it's the thing that is the biggest issue that we're dealing with. This is not a sideshow. This is the issue. This is the issue that we've been dealing with, or I would say a part of the orchestrated issue uh, related to the issue that we've been dealing with since 2020.
Could it potentially even be like an STD? It is a spirochete.
I wouldn't be surprised if those are related as well. That there's some relation, because I would say it's just intuition. Why all of a sudden this, are we dealing with all this syphilis? And, it's like all of a sudden all these things are like happening. And I don't think it's random. I think it's part of they're related. There's a relationship. Okay.
Well, I'd say it's sexually transmitted. In the villages, Lyme is pretty rampant there. I have to say,
That's a great
Where?
point.
Which villages?
The
in the
villages,
villages,
they're known for doing something where they put their keys in a fish tank when they leave the restaurant
swingers, yeah,
and they go
swingers.
home with whoever they pick the keys up with.
Yeah. Well, and you don't have to in my opinion, you do not necessarily have to be in a subsector of society in order to get this. I'm suggesting that this is part of the overall disease process that we're seeing. The problem is you're not seeing it on the conventional Lyme test. You're seeing it on the Zoomer test, but the Zoomer test can point to all the different fragments and how they are mimicking those different receptors and areas of concern, whether it's connective tissue inflammation, whether it's somebody with loss of speech, okay, because they've got antibodies that are voltage gated calcium channels. Are you starting to see something? This is going to be more clear. Why do they have nicotinic receptor antibodies? Why is it there always seem to be a fragment that mimics that is a Lyme fragment that causes the antibodies to be directed towards those, or the dopaminergic, or the DMA. Is that it? And NMDA receptors, which is the glutaminergic system of concentration and memory. Why is it so perfect and obvious? That's a good question. Is it that the Zoomer test is just not legitimate, or is it telling us something? In fact, I'm going to let you be the judge and not press me for, verifiable, undeniable proof, other than this is what I see over and over and over again. And it's so straightforward. It is, to me, it's what I'm seeing under the microscope. Is it possible this is all part of the same thing? Well, I think so. And I'm tired of not having anything to do about it. Okay, so I'm gonna keep my cool this time. But this is something to think about. And the thing to think about is the fact that they have a persister form that is seemingly impossible to break through. And what's suggested here is a step-by-step process as to how to break through that barrier. And when you break through those barriers, you can actually do something about this besides modulating besides just modulating the inflammation, and besides buffering oxidative stress, which is important. But we have a culprit here. We have a culprit that has been said. It's been stated clearly. It can come from the sky. It can be transmitted in other ways. It can be transmitted in food. It can be transmitted in water. Just consider that this is the case. Don't blow off the one thing that might actually make sense. All right, next. Okay, a conceptual model for, and if anybody has experience with Lyme, just, feel free to chime in. A conceptual model for rhythmic modulation of fibrin, chitin, or biofilm type barriers, which is exciting because actually you can see things that actually could represent biofilm. And you can see within them persister round cell-like areas. And so this is also a potential strategy for biofilm. And we've got this sort of fibrin chitin. This is the barrier here. So biological sequence: open, kill, clear, and rest. What that means is we gotta open up the various layers of the cell wall, or call it a spore, call it what you want, of the persister cell. Each phase engages a distinct physiological process: enzymatic softening, microbial reduction, detoxification, and restoration. The goal: controlled penetration and recovery without inflammatory overload. Focus on softening and dismantling outer fibrin sericin-like layers. Use systemic proteolytic enzymes. So this was part of the reason for serrapeptase. Although I have bad news for those who said that serrapeptase or lumbrokinase is everything. Why? Because there's different layers that need to be scraped off. And some of the really good enzyme combination supplements will have trypsin and chymotrypsin. I actually just checked one of mine, and lumbrokinase and serrapeptase. So you really want to really hit the fibrin, or the fibrin part, with these. And keep in mind, this is just for your understanding. There's also a connection. Just consider it. Don't try and prove me wrong or think that it's everything but, like usual. That there may be a connection between, if you think of silkworm, okay, and if you understand that they have a dormant state too, where they cocoon, and it starts off as a sort of like a worm, and then it has to break out of that cocoon shell. How does it do it? Well, guess what? It releases serrapeptase. Isn't that fascinating? That's fantastic news. That's the purpose of serrapeptase, is to loosen up the cocoon before it turns into a moth. Okay. And so the question is there a common denominator here? Okay. Now, where does chelation come in? Well, guess what? The wall is a matrix, and it has calcium, magnesium, and also zinc as the cross bridges, kind of like a regular building that has metals as part of the thing that holds the wall together. And did you ever wonder why there's such a deficiency in magnesium? Well, and why zinc is important, like really important. Um, well, consider this. Is it possible that we all have something in our bodies, all of us, and that it is stealing our magnesium to form its own cocoon? Just consider it. Maintain hydration to support peptide clearance and kidney function. When somebody is really, really ill, like this guy, or somebody who has a number of issues, maybe they have mast cell activation and things like that, that we always have to keep in mind that they are at risk for becoming inflamed once you burst through this matrix. Okay, once the matrix is opened, targeted antimicrobials reach deeper structures. Typical combinations being doxycycline, rifampin, azithromycin. Now, I'm going to throw in something that I think we should think about. Should we use doxycycline or should we use tetracycline? Okay, and there may be, and I don't have the answer yet, there may be a reason why tetracycline may be better. Or maybe we can just do azithromycin and rifampin. So we need something, and this is like days 3 and 4. For fungal components, I'm not familiar with caspofungin, but I think this is something we should look into. And so it sounds like to me like part of this. See, it's not antimicrobials by themselves. This is the time after the matrix is cleared that we come in with a multi-antimicrobial penetration approach. Days 5 and 6, detox.
Dr.
Yes.
Joseph, this is Dr. Patel, and you use word matrix, but matrix is quite different than biofilm. And what you are talking is about biofilm. You're not talking about real matrix.
No, and I'm glad you came in, because a lot of these things I'm trying to sort out in my own mind. And what I know about this cell wall is that there's a component of it that is cross-linking a protein matrix that is cross-linked. And I think that's what they're talking about. There's a polysaccharide component, and there's a which you could call which can be considered the chitosan component, because we do see that in fungus. And that's the other thing. Is this sort of how do we classify this thing? Is it just bacterial? Is it just fungal? Or is this sort of a combination thing? And then there's the metals which improve the stability of it. So when I say matrix, I think what it really means is the persister cell, the wall, that is the protein cross-linked part of it. That's the protein cross-linked. That's what they mean by the cross-linking proteins. I think that would be considered the matrix. Now, does that language, does that fit with some of the features of biofilm, Dr. Patel?
I think when we are talking about the biofilm and the persister cells, it is the intercellular organisms you are talking, and it can go through the cell, but it cannot go through the organisms. So the point is that you want to reach the organisms, and around the organisms are these all biofilm, which is like a multi-layer, like what you described, as it can be multiple different kind of layers, like intermingled with the some calcium or some magnesium or chitin or what in other proteins. So you are using proteolytic enzymes to disturb that, and as soon as you do that, and the cell persister cell is going to be destroyed at that point, because there is nothing, there is really no function. It is acting as a inflammatory molecule. So it is working, because it is working as an inflammatory molecule and secretions of lot of different cytokines. You have a more inflammation, which is cytokine induced, and indirectly we blame it on the organisms. But I think it is the multiple different molecules are playing a role here. So you may say it is the large amounts of protein, lipids, and toxins are released, and that's where they are microbial disruption, and then they are released within the cell, and then cell gets destroyed afterwards.
That the persister cell gets destroyed
Yeah.
after it's released from the biofilm?
Yeah, but when the biofilms are released, because when you give the antibiotics, it's not going to reach that. And even if it reaches that cell which is inflamed, that has to penetrate the inflamed cells, and it can go the intracellular, but it still does not kill the organisms.
Well, that's why, well, I'm glad
Okay.
you said that, because that's why it sounds like to me like this is we're speaking a similar language here, because like I said, it starts off with the serapeptase combination, to break down the fibrin part, which could be talking about the biofilm. But I was under the impression that there may be some crossover into the persister cells that they can become active again.
Yes, persister cells can have a fibrin around because of the inflammatory molecules, and that there will be the TET factor, which is like the thrombin antithrombin formation. Okay, so when they also trigger the coagulation cascade when that type of inflammation is there. So coagulation cascade, it's triggered. So increased fibrinogen when there is inflammation, increased fibrinogen activity, increased fibrin monomer, increase the thrombin antithrombin activity, prothrombin fragment 1 and 2. So all of that are part depending upon the degree of inflammation. So when you think patient is very inflamed, and if you see that you in your questionnaire that do you have a easy bruising? Okay, easy bruising is there. Is it vasculitis or it is the coagulation cascade triggering? And so you are running the vasculitis factors, yes, you would order the neurozoomer, but at the same time, you still need to run the autoimmune panel. Because if you run the autoimmune panel, an autoimmune panel shows that there are triggers, sometimes ANA positive, sometimes ANCA is positive, sometimes in early cases or not as severe cases, sometimes there is a positive rheumatoid factor, a positive ANA. Then you know that there is autoimmune, not autoimmune disease, but autoimmune activation. That means that we are seeing the polymorphism uh, in the um, in the immune cascade, and you T and T cell, whether there is a problem the with the autoimmune activation, taking care of the like IL-6, TH17, and T17, IL-6, 17, Treg. So those all are, it's a mental exercise that what am I dealing with? Am I dealing with this? Am I dealing with the vasculitis cascade? Am I dealing with the coagulation cascade? And unless you can do everything you say, but if you don't take care of that coagulation cascade, and you are taking care of that some by giving lumbrokinase, by giving something like what you mentioned before, the seropeptase and few other things, fibrin, something you mentioned before. So yes, that would help, but sometimes that is not enough. And then when you give large amount of the heparin to do the hemozone, sometimes that helps along with the other things. So what I'm trying to say is it is connective tissue matrix, but when you're talking about connective tissue matrix, there are about 5, 6 different components of that, and they all are, it may be if you're getting the autonomic nervous system involved, you may have a more the problems with the autonomic nerves, where the sensory nerves are involved, you have a problem with the sensory nerves. If you are involved with the fibroblasts, if you're involved with the mast cells, then and this is how these patients with the Lyme disease end up developing the mast cell activation, because there's a barrage of stimuli coming to them. So it I think that there are more things involved in it. And so when you say connective tissue matrix, we're not only talking about the peptide bridges, but the activation and workings of the whole thing. And usually the autoimmune fibers and sympathetic and parasympathetic fiber, mainly the sympathetic fibers are very close, zero point 0.2 micron close to the mast cells. And that's the reason many times you see the mast cell activation and dysautonomia, and patient has a problem with the parts like syndrome. And many patients, whether they are Lyme patients, chronic Lyme patients, whether they have a problem with the mold mycotoxin, they have a problem with the parts. And of course, the adrenal dysfunction does play a role. Thyroid does play a role, but I think when we are presenting these, it's very important that we talk about all that. And maybe sometime I may give the homeostasis and connective tissue matrix lectures so that can expound on it.
Awesome. No, thank you. Because that's really what is needed. This lecture is specifically pointing at, hey, this is something that takes multiple approaches to, that could be a way to dramatically decrease. Say if this were just a chronic Lyme issue, and there are biofilms that are connected to chronic Lyme, that this is one sort of way to think about it, is that it takes multiple things. Why do antibiotics not just work any by themselves? Or why do you hear of some people taking them when they've had it, for years, but this is intended mostly to say, hey, no, this is how it works. This is why there's a sequence. And then Dr. Patel, what you're talking about, that's what we really need. We need a broader sort of understanding of how to go about this and to diagnose things, like you said, the coagulation cascade, and also having a strategy so that we're not triggering Herxheimer reactions. I think that was, and that it's more than just, hey, I've got this chronic Lyme, do this, right? That's my impression. There's a lot more to it. So yeah, this is just a conceptual sort of narrow model of how of why this would be done in this manner. And of course, you see here, this is utilizing NAC, vitamin C to buffer the redox, and chlorella and activated charcoal to help bind in the gut all of these different toxins and fragments that may be then excreted through the liver and into the gut and need to be taken out and bound up. Otherwise, that can contribute to triggering the mast cells in the gut wall. And then, basic stuff like in hydration, that's just very important. Gentle movement, not working out hardcore during this process. The goal is hepatic and lymphatic clearance and terrain stabilization. Rest and reset, temporary pause for enzymatic and metabolic recalibration, focus, rest, electrolyte replacement, clean nutrition. I mean, it helps to have maybe an oligo scanner to know, have at least a basic picture of what the electrolytes look like, unless there's a better test. Dr. Patel, feel free to chime in.
Yeah, I have a one another at the beginning of the lecture. I think Stefan said that you want to order this test, but I want to start the treatment. That that really I did not say anything at that time. But when chronically ill patients, don't rush them to the treatment without finding out. If they have seen half a dozen or a dozen physicians or paramedical people, and then you try to accumulate what they have done. But just don't rush to the treatment because, one person has done this, one person has done this. Lot of things what you are mentioning here that some paramedics or medics have done it, but patient is not better. So you have to really figure it out why patient is not better before you run the test, before at least you try to mentally analyze that, okay, this is the full picture of the patient, and this part has been worked, only this part has been not done. So figure out that this body is a barrel, and everything comes in that barrel is full, and then there is overflow. Everybody has tried to do something, but that has not lowered the load total toxic burden or total body burden, and then you go at it. But I think you just go at random. You have not addressed the cause. You may have addressed it partially, but it's not going to do much, because I mean, you and I and everybody else sees the chronic patients, but somebody is seeing worse of the worst of the worst, and very few patients they see. They don't see 10, 15 patients a day. So my thing is, don't rush into the treatment. And so if you patient wants to be treated, you just say, yes, we are going to treat you, but let's first find out that why you are getting sick, one is getting sicker, or other treatments are not helping you, or something of that sort.
Yeah, no, I like that. Not only because you have the experience and you know what you're doing, Dr. Patel, the one thing that struck me in having literally all, like you said, just treating the sickest of the sick is trying to figure out, and Stefan, you're on your way too, because I can see it, because I know, I know exactly where you're at and where you're thinking. I can tell you one thing, at least, and Dr. Patel, you can correct me anytime, that once I got a bigger picture, I actually had a more solid diagnosis. Then I was able, and it seems to be, now again, this is where I'm at. It seems to be chronic Lyme is sort of like the initiator of it, of this, say, specific antibodies to a specific area, say like this, this aquaporin antibody, optic neuromyelitis syndrome, which was, I never heard of that before, but you can see it on the test. What I can say is I was able to organize my thinking as to what's the primary driver and then what are magnifiers. And you had mentioned treating the Epstein-Barr. Well, I can say that it seems to me that the Epstein-Barr and the other cytomegalovirus and the streptococcus may be acting more as magnifiers, including mycotoxins are also, they play a role in this whole orchestra, especially breaking down the blood-brain barrier to, lead to some sort of a mimic-like antibody response to the brain, because there are all of these confusing, doesn't make sense. They were a top-tier athlete, and now they're debilitated. It's not normal, but it seems like it's coming from this chronic Lyme that I'm seeing on the Zoomer test. And so that sort of, you could say that that's a primary driver. The diagnosis is actually, where are the antibodies high going to? And if it's going to a part of the neurology that explains the symptoms, that may be the place where, okay, you've got a diagnosis. Your primary driver may be the Lyme, and then everything else is a magnifier. And so this is sort of a way to think about going after the driver. And I'm here to say, because there's this biofilm component, and there's this persister cell issue, and that these persister cells, they may be atypical too. That's another thing that I'm starting to arrive, because I'm kind of late onto this how do you treat Lyme scene, that part of this may be, how do you eliminate the persisters once they're released?
Can I add one more thing?
Yes, no, please. I'm asking, please
So
help.
I think, as you mentioned, that chronic Lyme may be a real driver, but I think there is one more thing over and above the chronic Lyme, and that is the sequestration of toxins, environmental toxins in the connective tissue matrix, which makes all cells malfunction, including the lymphocytes, including the sympathetic, parasympathetic nervous system, mast cell, fibroblasts, macrophages, and some may be downregulated, some may be upregulated. And so why many times we see that two equal people were had a tick bite, and in the same area, hopefully it is the same genus, same toxicity, and one gets sick and very sick, may not get very sick now, but maybe a year later or 6 months later or 12 months later, well, the other ones is fine. You look at the lifestyle, you look at how they are doing. I had a patient that who was doing perfectly fine after the treatment, but then he got an alcohol binge. And I said, how much do you drink? And he was just coming every 3 months just for the simple follow-up, because we stopped the treatment. Stop the treatment means the antibiotic treatment. Told him to continue the rest of the environmental control and glass bottled water, organic food, uh, his nutrients, probiotics, etc. But then I still, it is very important to see that what do they drink, because young men in their 30s, 40s, they are going to drink. And he said, well, I come home and I distress myself. I say, how do you distress yourself? But they're never going to tell you that they are drinking this much alcohol. Oh, well, I have a few bottles of beer. And then I said, what about then Friday, Saturday, Sunday? And then comes out, okay, I have 6 packs, and then I have one or two hard liquor drink, and this. So a whole week, if you see, they have 12 to 24 bottles of beer and other drink. I mean, how are they going to detoxify?
Well, yeah. I mean, can I tell you that for some reason I seem to get a lot of patients who have impeccable lifestyles and incredible high end um, diets and the best of the best.
Yeah, okay.
You know,
So, so
and
did you?
what I'm trying to say is it possible that starting in 2025 that you can be perfect and still be a victim to something that is happening to us?
Yes, you
Okay.
can. You
Okay.
can. Okay.
Like there's something serious
Yeah.
going on right now.
Yes.
Okay. And
Okay, but you were not born today, right?
it's not everybody's fault. They don't have, it's not be, oh, if they would just stop doing that or take off their shoes and dance on the beach, they'd be fixed. No, they are poisoned.
I agree with that, and like you brought to their attention the microplastics. That was wonderful, and microplastics, not just the physical presence of microplastic in the tissue, but their biological activity, because they are similar to all the toxins, chlorinated toxins, hydrocarbons, uh, and so you have to detoxify them. Not only that, but they have effect on the lymphatic system, mast cells, this, that. So you think that a patient is having very clean life, not drinking this, eating organic food. But what about everything what is sequestered in their body until now? That how it's going to be processed. And like you mentioned about the hydration or the oxygenation, they're all important. Electrolyte replacement, clean nutrition. But what about the garbage that is there still holding in their body?
Yeah, I totally agree. And the way that I've come to see it, and let me know if you see it similar, is that everybody is exposed now. Nobody's living on Bali in some remote island with no electromagnetic, with no toxins and no electromagnet, and that this is a this is a unprecedented time, and that it's epigenetically determined. If you are one of those people, if you've got bottlenecks in multiple detoxification pathways, meaning that your genes were not designed for this this crazy show. This world, they were not designed for this barrage and this poisoning. Okay. And that some people, if they don't have that genetic predisposition, they're not going to know. They're going to say it's fine. The world's fine. Everything's fine. But those who have it, they are on their deathbed because of that. And yes, so then we have to focus then on detoxification. Then cleaning. Sounds like what I'm hearing is we need to clean the body as much as possible through various strategies. I as far as I know, we've got different, if you can see the different bottlenecks, you'd have to get them maybe perhaps a genetic testing, and then you can target those pathways with the things that each pathway needs to ensure. I mean, methylation is the most obvious one, with methylated B12 and folate and those things. Then you've got the sulfation pathway to get rid of the excess estrogens and the BPA and and phenols in general, that those need to be optimized. Meanwhile, the patient, based on the chronic disease model, has to be, their inflammation has to be modulated, because they're usually over, it's a dysregulated immune system because of all of these things, and because of the COVID related weapon. It causes an exaggerated immune response, especially in somebody who has say a Th17 exaggerated response, somebody who's going to be prone to psoriasis and Crohn's and multiple sclerosis, and many of the autoimmune diseases that we see are connected to a hyper reactive, let's just call it for what it is, a strong immune system designed to fight real pathogens, not confusing pathogens. This isn't normal. So, and then we've got to buffer the redox. We've got to get we have to get the redox status more balanced. We've got to get the immune balanced, right? And then we have to get the metabolic and the hormones addressed. That's a big issue. That's going to be a part of helping with the inflammation and buffer the inflammation, is to make sure, like my patient in New York, not realizing right away that he actually had a history, 27 years old, tennis player, top tier. Now he looks like somebody who's on death's door. That's why I always say, oh, hey guys, guess what? There are sick people in the world, especially in the middle of a serious situation like now, that we, have to try to get him optimized. He's in hormonal shutdown. All right. And then there's a whole nother area that I suggested, maybe we should also look at research, because that's how it has to be, research into neurosteroids. The DHEA-S and pregnenolone S, there's a difference. They don't turn into estrogen and testosterone. They've got one job for the most part. Is guess what? Modulate Th17, interleukin 6, TNF alpha, and to modulate the neuroimmune system. Literally, the microglia, getting the neural pathways to fire appropriately, modulate the voltage-gated calcium channels so they're not having complex pain syndrome. I mean, think about that. If that's really the misfiring, the spark plugs of the nervous system that are responsible for pushing or sparking the neurotransmitters to transmit to the next nerve and so forth, if that is misfiring, especially in the presence of demyelinating disease.
Yeah, that's brilliant.
Right? Exactly. And so we've got to get these other issues and get that under the control, because then if you try to detoxify, obviously, depending on how, and that's something I think we should definitely talk about, how exactly, what is a good place to start with detoxification besides just supplementing the bottlenecks. And I'm starting to become like some of the people I've come across said, no, I don't use synthetic nutraceuticals. I thought, why? Well, I think we might want to take a second look at them and look at their quality. Well, it's because I'm seeing some interesting things. But and the other thing, believe it or not, I'm actually looking at the herbals. And the only reason why I didn't is because I never understood what in the heck they did. But now that I'm starting to see how they really are, and I mean, I could be wrong, but they seem to be doing all of these things, breaking up the biofilms, breaking up these imaginary pathogens that we can't seem to put our finger on. That's why they're so important.
They are. And so I put this kid on pregnenolone just for exactly as you described, because this is a neuroinflammation that we're dealing with, and they need to be on pregnenolone to protect their brain. And of course, I also put them on LDN for the neuroinflammation, the nerve inflammation. But as you said, we need to start with the basics, the funnel. It's pregnenolone and DHEA. They're neurosteroids. They're more than just, a precursor of testosterone or something,
Yeah, exactly. And if it gets to the level that they are unable to, when you measure the DHEAS and it's low, and you know that, and you suspect or you have evidence that they have detoxification bottlenecks, then you know that even if you gave the pregnenolone or the DHEA, now there is a way to do this if somebody's fairly stable, and this is from getting really good advice, that if you go very high with those doses, much higher than we, at least I typically thought. I mean, we're talking like 5 to 10 times the normal dose, that may allow for the conversion, enough of it to be converted to their sulfated form, because that's the part that does the neuromodulation. And so, being somewhat new at that strategy, I do like the idea of, if we have availability of the sulfated ones already. I mean, they're not at the normal compounding pharmacies. They're for research purposes, which means, well, I mean, my intuition tells me it actually would be the greatest thing to have, but sometimes when things are too good to be true, it's because sometimes the best things are not necessarily easy to find.
If you're getting into herbals, the two good companies you got to work with are Quicksilver and Biocidin. They have good herbal products for this.
I'll take a look into it. What I'm talking about is actually having the herbs. I'm talking about the plants. I know. I never.
Like making your own tinctures and stuff.
Yeah,
I took a course on that once by a naturopath. I'll tell you what, it's I like Quicksilver and Biocidin because they found that ancient Chinese remedy that they brew up in the back and they don't tell you what it is, and they found it and they put it in a bottle for us to buy.
Well, and no, and I understand where you're coming from. My only concern is this. Either they're not as potent as you could make them when you make them yourself. You got to know what you're targeting. Okay, you got to know exactly why you're doing. And for me, again, I'm sorry I'm such a rule breaker, but I check under the microscope to look at the results. And when I see that clearing up, that tells me, that gives me the answer, because it's hard to tell in these situations where we'll put it like this. It helps to have somebody who has already sort of figured it out, and then they can kind of save you the pain of testing 200, 300 different herbs, and you can just go straight to the herb. Like, well, what would be a good example? Holy basil.
Cat's claw.
Cat's claw would be a good one. I only know right now, and until I test it, that holy basil has a heck of a lot of uses. And guess what? it scrapes away. I was always wondering, well, it always says it does this, it does that, blah, 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 until I
The
found out.
most important thing, it does not have any side effects.
Yeah, right. There's no
The holy basil in lot of Indian homes, we have it, okay? And you put in your tea, or you grind and put in your spread or something like that. So that helps even to remove the biofilm in your intestines, because it's a, whether you're sick or not, you just have to keep your gut clean and biofilm free, and the thin mucus layer, just proper amount of a mucus layer in the gut. So you're right that they have found it's been, I think, last 25-30 years there was a company that who brought it in a form of capsules or tincture, and it's helping a lot. So similarly, there are homeopathic drainage formulas which are very good, called lymph drain, liver drain, kidney drain. So before even you start your patient on anything, any antibiotic or anything, you start patients on a drainage formulas, probiotic, prebiotic, whatever is applicable at the time, and prepare the terrain before you start killing and releasing the more toxins and getting people sick. So it is something very important. And yes, herbal can be very part of it. Even in they have shown that certain herbs are equally effective, like doxycycline or other antibiotics. So, and they have done the test. There was a lab in Connecticut, and I don't recall the name of the doctor that she was doing it. She presented many of her studies at a Lyme meeting, ILATS meeting, and it was effective. So when you try your antibiotic and then you want to go up antibiotic, you can like Samento or Benderal or um, herbs like that, or cat's claw, like what is said. But you have to make sure if you're using cat's claw, they are not on any other SSRI medication. Otherwise, they have a more problems, urinary trichitis or things like that.
What about Dr. Patel? What about neem?
Oh,
NEE.
neem is also very excellent, and many of patients, they have a gum disease, they have a teeth problem, and you can use the neem toothpaste, and it will start healing. Like other time, Dr. Clearfield was telling about using bicarb and some castor oil, or I'm not too sure which other oil, sunflower oil, whatever was it, and then you gargle with it. But some patients can do that, but some really need the toothpaste. The neem toothpaste is one of the best toothpaste. And then there is another toothpaste which uses the cloves also in the toothpaste. And so it is another toothpaste that is also a herbal toothpaste. So that one is good. There are cloves, real clove powder capsules that you use, and it helps in clearing out the dysbiosis. So you brought a very good subject, that you have started using herbals. I've been using it for last 25 years in my practice. And I think you have to use all of the above. You can use the homeopathic, you can use the herbal, you can use the antibiotic, and you can use many other non-antibiotic. Your food is your biggest remedy. Okay. Your water has to be very clean, and non-plasticized bottle, not even, I would say, the stainless steel bottle. It should be pure glass bottle. And pure glass bottle, now they have a very good plastic covering, rubber covering on it, so it doesn't break. So I think we have to have a real, if we don't drink, if our patient sees what we eat and what we drink, okay, and they see that we are drinking from real glass bottle, that makes a difference. And you can tell them that do not drink, because that is one of the factor chronically making you sick. and microplastics, nanoplastics. Just go and do the search on nanoplastic and microplastic and see what role it plays in the genesis of your illness. Because we
Yeah.
have to educate our patients. We can provide them, but we say that we don't want you to pay money to us to bring. We can tell you, and then you go, unless they are like 70, 80 years old and they're not going to do it. But 30, 40, 50, 60 years old, they can all do that.
Yeah, I totally agree. And it's, the epiphany came when I realized, gosh, it's hard to find something that doesn't either have aluminum, it's not in an aluminum bottle, or it's not plastic, or, and again, I'm seeing a lot of contamination
Right.
um at the same time. And we know, especially when you're at that breaking point.
And then stainless steel bottle, I mean, that is epidemic. Everybody comes in your office with stainless steel bottle, right? So they are loaded with nickel and chromium. And the physician has to know if the patient has that. You just say, oh, it is nice to have that, but it is a ceramic lined. What? What are you talking, doc? Here, there is a ceramic, and if you line it with that, then you will not get poisoned by nickel or by, because the water is not, when we drink water, it's slightly on acidic side. When if they put a little bit of lemon juice or lemonade water, then it is very acidic and it leaches out the large amount of nickel and chromium. And then the patient develops the accumulation in their body and develops the different kind of chromium, gives you a lot of autoimmune problem, uh, and nickel is also giving you uh, the problem with the lymphocyte abnormalities and other toxicities. So I think more you learn, you all what you have to tell the patients that I want you to go home and then we will, if you have any question, we will discuss. But and then you do the chelation challenge test and show them that you have a toxic metal overload in your body, and you do pre-challenge and post-challenge urine. So pre-challenge is going to be your baseline, and then you give them the challenge, and then you show the report from that challenge after 6 hours collection of urine. And then it's not a very expensive test, and they can just see that what came out of their body. And it's not like amalgam, it is like layered in the body like a Grand Canyon. So sometime when you try to get that layer out, and then something else comes out, then something else comes out, but you are, in essence, you are, every time you do chelation, you're lowering the total body burden of the toxic metal.
Yeah.
And it will leach out your good essential nutrients, but then you have to replace them. But you have to do again in a right way. You can just not go and start that. You have to know what other ingredients to put it in the IV to balance it and make it the optimal infusion for the patient.
So this sounds like, and you don't have to get into it, but it sounds like IV EDTA, and then with appropriate mineralization and maybe some other things, is one way that chelation
Maybe.
has been done.
And that will help so also the breakdown, the biofilm too. So, it does the multiple really benefits to the patient, and the
Good.
condition improves.
I've been using this product from Quicksilver. It's an EDTA sublingual.
Yeah, yeah, yeah. But it's a, you can do the challenge. It depends upon, on an ongoing basis you can do that, but you have to lower their load. I mean, there are suppositories too to to do that similarly.
Suppository.
Well, my understanding is that when somebody is severely toxic overloaded, especially with heavy metals, I mean, I see it with every single patient that
Right,
they're
exactly.
it's just a matter of whether or not they feel anything, which is so it's amazing. You know, if you don't have hyperinflammation, you don't have mast activation, you're going to be dancing around like
It
everything's
will,
fine when it's not.
it
But
will calm down. It will calm down, even mast cell activation. So,
but my impression, my understanding is that we need the IVs when they're at a certain level of toxicity. And these are all great thoughts. Stefan, you're on it. It's just I've had to figure out, does a sublingual do the job by itself, or does it require a stronger therapy, especially in somebody who's really, really sick? Maybe the IV, and then you can replenish the minerals that way. That may be a more potent way to actually get the results. The sublingual way is a more of a maintenance plan. You know what I mean? Dr. Patel, I'm deferring to you sort
no,
of.
no, no, you're absolutely right. When patient is toxic, it's just like patient is nauseated and vomiting, and I mean, and you give them sublingual Zofran, what is it going to do? But if you the minute you give the IV Zofran, and then they are much better. So that is the fastest route of delivery, and effectiveness is optimal, and patients is free of agony, and that's what we want when patient is really toxic. And it is not a one-pronged approach. It improves the endothelial function, it improves the microcirculation, it improves the, so it has a multiple, not just it reduces the total load of toxic metal. It does multiple beneficial, has a multiple beneficial effects.
Thank you. Yeah, it's Stefan again. I think we're in a similar situation, me and you. I've had a few more cases than you to kind of arrive at my conclusions. But yeah, I think we just need a conceptual framework, where, you know, more details. Yeah, we know the basic pillars, but especially when it comes to detoxification, like how many IVs, how many times per week, for how long, can we get away with an oligo scanner to look at the metals? Is that accurate enough? These are some of the, maybe Dr. Patel, if like I said, if you're able to, I think that's a missing piece of our education, is we're trying to navigate this extreme this now toxicity. It's not just this person, it's everyone I check, that maybe we need to have a better guidance from somebody with experience to help save us some of the legwork of trying to piece it together and have a more of a, not a protocol, but a way to see it and to understand where to start.
Yeah, when you're doing the history, you mentally analyze what part you want to emphasize in your history, because history, your patient already filled out whatever history forms you have. I have like 12, 14 history forms that they must fill it out, so that immediately I can start um, the problem or no problem, problem or no problem. So you can evaluate the patients a little bit faster and put the emphasis where you want to when you're taking the oral history. And I usually don't look at somebody's workup. I will look at some of the blood tests that they have done. And sometimes patient comes and wants you to look at it. Okay, you look at it, but don't bias your mind with the previous physician's diagnosis, because that's the most common mistake people make. because then you will start thinking in that direction. You independently make your diagnosis from patients' complaints, and then you go from there, and then you think what you would order, and then see what patient has brought and does it. So then you can rule out right from there. Of course, you will need certain basic things, but it will be helpful to you. But I think the most common mistake people make is take somebody else's diagnosis and work from there.
I've done that until what I was doing wasn't working, and then we had to go figure it out. And then when we figured it out, I was like, shit, excuse my language, but we should have, you know, maybe should have started there. I just assumed it was at this level.
Yeah.
Yeah. Okay. Well, I guess I'll just finish this up and then we'll open up for
Thank you
questions.
all, and sorry for interruption.
No, you actually made this lecture. You made the lecture literally because this is just opening up the door really, and your input has been very valuable. I appreciate it. Thank you. So just a basic rhythm of when the timing is right to go after the biofilms, perhaps open, kill, clear, rest, open, kill, clear, rest. The enzymes loosen the structural barriers. Oh, and by the way, holy basil and neem may do all of these things. The combination, they loosen the structural barriers. They literally chelate the specific metals that are part of the holding the matrix together, whether it's the biofilm or the wall of the persistor cell. Okay, that again, just I'm not proving that the persistor has a wall. I'm just seeing evidence that it could, that it's atypical and it's tough and it needs all of these things, and it has the antibacterial action to with the so-called open matrix after the structural barriers are open. That's where they play, but so do those two herbs without the side effects. And they're potent. Don't think that they're not potent when they are done right. That's at least that's what I couldn't imagine that they could be potent. Just because you don't feel it in 2 seconds, but if you give it day 1, day 2, day 3, that could be different. I mean, I'm seeing that their impact has been more impactful, at least what I can see under the microscope. Now that's a reality. Detoxifiers clear the residual fragments. Recovery day stabilizes function and prevents overload. It's a little bit vague, but pacing 5 active days, 2 rest days. And I've come across different citations or ideologies from Lyme books or what different practices do, and they do certain things 5 days out of 7, and they do antibiotics for a certain amount of days consistently. And so I was always curious, what was the context? Why this, why that? No, because there's a way to loosen up these barriers. There's a way to go in there and impact the other layers. Basically 3 different layers that we're working with. Polysaccharide, like the chitin component. We've got the protein matrix cross-linked, which is the fibrin. And then we've got the metals that need to be pulled out because they're kind of holding everything together. And that's why you see this multi approach. So hopefully that wasn't too confusing. Here's some articles to check out, just so it will make it's hard to find this information, it seems like, but collectively these references give different pieces of the puzzle. And that's it. Stefan.
Yes.
Talk to me. How do you feel? Where are you at now?
That's great. Have you ever heard of the Nutramedics and Cowden protocol?
No.
I'm going to introduce you to it. I've used it a couple times for Lyme patients, and it's a protocol with all these herbals. Um, it's everything in a protocol. Serapeptase, everything you discussed here, they have it. Serapeptase, holy basil, all these herbs, and it's designed for treating Lyme.
Yeah, and again, it's like this is the conceptual model. You have to break down the it's those persister cells. That's the problem. That's the reason. And the fact that this is an atypical, I think it's an atypical line with components that are tougher and harder to break through. It's as if that matrix is made of glass. Glass. That's why. And if you look at it, actually, you'll see it. Why does it look like glass? Because it's kind of like glass. That's what it is. That's why it's so hard to, and if you can do that, you basically, in my opinion, you're solving the whole COVID syndrome. Basically, all of the issues that we're seeing can be somehow related to this phenomena, and the ones that are not getting better is because there's this issue that, first of all, they don't have a firm diagnosis. I'm here to say most likely it's a Lyme phenomena because I see it in everybody I test, and it's just because it's an intuition thing too. It's like after a while you start to see that the pattern is, oh my God, this is because we're not told the truth. That's the reason we have to figure this stuff out ourselves. And the reason for the herbals and this, what you're talking about, sounds like we're on the same page, is because of the biofilms and the persister cells. They are hard to break open. You'll never get rid of an autoimmune issue if you can't stop the persistent inflammation and stop the persisters. Perhaps they can become back active and switch into this and that and the other thing. You're never going to get better. So you have to have a strategy and know why what's doing what, why this herb is doing this, is scraping off that it's the fibrinolytic part, helping. It's what if you connect the serapeptase and the silkworm and its cocoon, that's its purpose. The cocoon is that hard, it's tough. It's hard to break open. And you'll see a lot of references to silk, by the way, if you look for it, that there's a silky connection to this whole phenomena, that there's a reason why these walls are like silk.
Yep.
That's all I'm going to say about that. All right, awesome. What else?
That's good. Yeah, I'm going to use that. I'm going to use the Cowden protocol. I'm going to connect you with Nutramedics so you can start using this too. Other things I was thinking about using LL37, the peptide. I've used that for Lyme before, and people notice it. And when they have Lyme, they'll react to LL37. They'll have
Do me a favor. We've got this other issue. If you want to learn how to use a microscope, you can come over to my office.
Yeah.
It's not the devil. It's just basic medicine, but I look at the supplements now and I look at the peptides before I use them. And the reason is I don't like it when I see scary things within my own supplements, and I'm seeing it more and more, which is why I'm moving towards. I'm not saying that Quicksilver is not a great brand. It's just I don't know what to trust anymore. That's the problem. I look at the food, I look at the water. I mean, as many things as I can now until I can see it like, wow, it looks clean. What I see is something that looks like persister cells. I'll just give you a clue. Looks like persister cells. And they have a distinct look. And I know it doesn't make sense necessarily unless you think in terms of something's happening with our food supply. Now, when I have several patients from different countries tell me all at the same time, I feel like when I eat something, it feels like poison going to my head. That to me is a very real thing. In fact, I don't feel good when I eat food most of the time. Why is that? That's not normal. Well, if we looked under the microscope, I think we might be pleasantly surprised. I've seen these things in tap water. I've seen it in restaurant food. I've seen it in food that's supposed to be the best of the best. I've seen it in supplements that are supposed to be the best of the best, the expensive ones. And I look under there, I'm like, are you kidding me? And I look again, and yes, I clean my slides, and yes, I do all the things that, it's
course.
everything, but it cannot be. Did you do this? Did you do that? I was like, do you look at a microscope ever? Why don't you come take a look? Serious, man. My life is like living in the twilight zone. Anyways, anybody have any questions?
No, that's good enough.
Anybody?
John Burgess is waking up there on the screen. He's waving at us,
Who?
waving some fingers. John Burgess. He's
Oh.
he's waving at us. I don't know if he means to say something.
Unmute. Hello,
There.
everybody.
Hey,
Hi.
Hey, during this whole discussion, nobody said anything about bioweapons or Plum Island. Is that crossed anyone's mind?
oh, don't get Joseph started.
Plum
Okay, I
Island?
won't. I was wondering if that's why we didn't say anything, because we could go on for
We
a
can go on
long
for
time.
3 hours about that.
But Lime is so different. Lime is just so weird. I mean, we've all gone through our circles with that, and it's hard to figure out, exactly what that is.
Yeah, and that's why I say, look, I think we should start looking instead of imagining what's going through the laboratory computers. Get a feel for what it looks like or what you're seeing, something that is causing an issue with the red cells. And you don't have to call it a name. You don't have to just say there's an unidentified structure. Okay, these ones they just happen to be very round, and they have the look of a persister cell that is not typical.
Yeah.
And what's that?
Well, I forgot what I was going to say. It's just that I'm thinking of a few of these things like Lyme and AIDS and COVID all start hopping around at the same time. And I just wonder because there's a whole bunch of stuff about uh, the AIDS. Because if we're talking, I don't know if you ever kind of in your mind somehow connect the two, Lyme and AIDS.
Yeah, yeah. Well, no, I'm glad you're saying this. Yeah, my CD4 count was low, like 3 years ago. I mean, and 2 years ago as well. I mean, it's like it doesn't show it on the CBC, but it shows it on the lymphocyte map. Anyways, go ahead. Lyme and immune deficiency.
Well, the reason I listen to you and Stefan and Dr. Patel is because this is too complicated for me. I've been working on it for so long, but I still don't know much except some of the stuff you're saying. Try to get healthy.
Well, yeah, and that's why I try to simplify this and say whether you call it a parasite, whether you call it Lyme's, whether you call it COVID, I'm here to say you can see it infecting your immune cells. You can see it gobbling them up. You can see them tearing up your red cells. It's you don't have to be more than the third grade to see it. I don't know why we have to study our whole lives and know everything under the sun, and we can't even use a toy microscope and make a conclusion. Something's wrong with that.
Yeah. So let me ask one more question because you do a lot with a scope. Have you contacted Nick Delgado?
Yeah.
Nick Delgado is like he was the leader in the scope and live cells for a long
Oh, yeah.
time.
Yeah.
And he was right on everything he tends to say. He tends to be right. So if he goes quiet about something, it's not that he hasn't discovered it. He's not allowed to discuss it. But anyway,
That's what I
but
suspect.
yeah, and the live cell stuff is major, incredible, in your face. And with Nick, he would find out if there's roulette formation, and then he'd do a couple of simple things, and the roulettes would go away, and you get oxygen again. So that's what he was about. But I think you're taking it way farther.
Well, I'm taking it farther because I watched the blood get worse and worse to the point where I'm looking at the blood from people and I'm saying, how is it possible that they're walking around?
Right. Have you seen creepy crawlies under your scope?
Oh yeah, yeah. I'm not allowed to talk about them, but
Okay.
you know,
I'm going to keep my mouth. I'm going to keep my mouth shut. When we get together sometime, we can talk more about this. But there's so much happening right now that is about to be disclosed by the United States government. I don't know how much they're going to say, but they're going to say things that they were denying for 50 years.
oh, I have an idea. But I'm curious to and again, look, we're a small group. We don't advertise, you know, anything really. Everything is here. It's just between 10 people with me talking about the microscope, you
It's
know,
it's a big deal.
and
Anybody who looks at the scope is going to find out it's a big deal. It's just real.
thank you.
Yeah.
And at this point, I mean, look, things are heating up, and I think it's a good idea to have something so you can see what's going in your mouth and see what if your supplements are sound. To be able to test what you're dealing with the water, you got to know what's going on. You can't. It's hard to believe that everything could be working against us, but it seems to be the case. And I'm just pointing out that we have to get over this hump of I know it's hard to keep learning new things. You pick it up really really quick. um I've only known one other person in another state that really got into it, and they were an amazing wealth of information, beyond life game changer for me. Without that kind of gut level knowledge, because seeing is believing, you're left with trying to interpret literature that's in a way, meant to be confusing, so that you can't put two and two together, especially if you don't even know if the study is legitimate.
Yeah.
Talking about one thing and you're seeing something different, and you're like, wait a minute, what's going on?
Well, even before Nick Delgado and a lot of other people, we had the trial and persecution of Gaston Nissan in Canada, who was the microscope guy with polarized light. And he discovered major things, and he also developed formulas. And they put him in jail and put him on trial to put him away for life. The reason I mentioned that book and him, he was acquitted. So the things these scientists under scopes are saying, they're threatened with life in jail, but so far they've all been either acquitted or killed, but you haven't heard much about it.
Well, I'm not so worried. I'm not really interested in this life anymore, to be honest. I've had enough of this clown show. I can take me out. Seriously. I'm not gonna look under a microscope and look at what I'm eating. If it gets to that point, just the hell with it. I'm out of here.
Yeah.
I'm
If you
not,
could be
I'm
honest,
not, I'm not changing the narrative. I'm just telling 10 people in our group, and I'm trying to talk about the things that are relevant now, not good topics. I'm talking about, how do we survive now?
we have 100 in our group who are telling the truth. That's what we do. That's why we are together. I'm one of those who was taken out by the feds. I get it. I see what they do. I know what they do. But we have a lot of honest people here with integrity. And that's why we are doing our own independent thing, because most people have sold out or they're scared shitless.
Yeah, take me out. Seriously, take me out. I don't want to be here anyways. I'm not saying that because I'm depressed. I'm saying I've seen too much nonsense to say it's not even worth it. This is a clown show. It's an
All right,
evil
we'll show you
clown
some
show.
good stuff. We'll show you. I'll show you some good stuff so you can be re-inspired again. If you just listen to Stefan, you're gonna be inspired.
I'm inspired. I'm still inspired. Don't get me wrong. I'm just saying, look, I'm not going to go against principle and be a complete put the blinders on or be completely ignorant after doing this much work and studying to what? To know nothing?
Maybe I can't figure it out. I'm confused.
Be a dumbass?
Maybe.
To be the lowest form of life? Forget about it. Well, anyways, I didn't want to go there, but I did. Maybe next time. Maybe next time I'll be nice and pleasant and calm
No, there's a
and tell
lot of stuff.
everybody that everything's great.
There's a lot of stuff going on in the world, including the peace in the Mideast. We have an opportunity now we haven't had for 50 years. So hopefully we can discuss with other countries, other people, other cultures, what they're doing to get people well and get the sharing going again. Because that's what we were doing, a long time ago.
Yeah, and that's what the patients who are scared to death, that people get sick and they die, but 27-year-old who could be helped, who's like literally dying, like the body is the muscles, the bone, the shoulder joint coming out of the joint. I mean, two shoulder joints, like has a hold up an arm, has almost no muscle mass, a top tier athlete, literally turning to ashes while being conscious. You better believe I'm going to help them. There's no way. There's no way. There's no getting out of it, trying to figure out what's going on. The fact that a doctor can't try to figure out what's going on is beyond me. If that's the way it is, get me out of here. I'm done. And I'm serious about that. There's
We
nothing
believe
to go for but to,
we believe you.
to try to alleviate suffering.
I think there are a lot of us out here that are just like you, Joseph.
Well,
I think there are a lot that have put their life on the line and dedicated decades and decades of time and service to other people. And now we have a collection of these people and we're going to do something about it. And we are doing something about it.
yeah. No, that's good to hear. I appreciate that. And when I say that, I'm not saying it to you. I'm just saying it to get it out of, I'm trying to get the reality out. I'm not, putting on a facade and pretending everything's fine. It doesn't work for me. I can try it all day long. It doesn't. Eventually I'm going to start getting into it like now and say, look, this is what's going on. Can we not talk about what's going on? There's no more time for pretending. Burgess, you just faded away.
Uh, I'm there. I don't want to take any more time with this. It's
All
all
right.
serious stuff. I mean, most of us here at this meeting have put our lifetime into trying to do the right thing. So I see a lot of good stuff that can happen, and we're all trying to do that. That's
Perfect.
what our job. That's what our job is, to reduce suffering and death. And pretty simple.
Awesome.
Yep.
All right.
Anyway, thanks for talking. I'm gonna get out of the way.
Okay. No, I'm done. Anybody else? Otherwise, I think we should just
Good night.
rest.
We did good here.
Yeah.
Peace.
So yeah, send me whatever that protocol is and
I
all
will. Connected you via email.
right, awesome. Cool. Anything else?
That's all. Bye, guys.
All right.
Bye.
Okay, have a good night. Thank you.
Night.